enough time to present. So before I give a formal introduction, just to update you here, Raymond, this is our digital hub or digital health hub group. We are multidisciplinary group across multiple schools at health sciences at University of Pittsburgh, mainly School of Nursing, Health Rehabilitation Sciences. We have pharmacy and public health, and School of Medicine. And it seems this week is the finals week, so we do not see any trainees because usually we have faculty. All of us on this call are, professors from different schools. We usually expect around 15, 20 people, along between faculty and students. So we're going to record this presentation if you don't mind, so we can share it with all other trainees who couldn't come due to the finals. And with that, I would like to introduce, Raymond to the group. So Dr. Raymond Bond is a professor of human computer systems, and he has research in the application of healthcare informatics and digital health. Raymond's work has involved human-computer interaction and data science machine learning techniques in healthcare. His work has involved modeling, processing, and visualizing of medical data to enhance clinical decision-making, including the creation of interactive decision support systems. Dr. Decision support systems. Sir. Okay, I hear myself here. I'm not sure if others can hear this echo.
I can hear you. Okay. I'll mute my.
Okay. Raymond has also research interests in computerized simulation-based training in healthcare, usability engineering, and user experience data analysis to improve medical device. Also interest in eye gaze analytics in clinical decision-making. He also has been involved in designing and evaluating digital health and well-being interventions, including apps and chatbots. And Dr. Raymond has over 400 research outputs, and he has chaired and co-chaired a number of conferences, including the 32nd International BCS Human-Computer Interaction Conference, the 45th and 46th Annual Conference of the International Society of Computerized ECG. This is the ISCI conference, and Raymond and I have been co-chairs last year of this conference, and we worked extensively for the last couple of years, putting that conference together. And he also has chaired the 31st Annual European Conference of Cognitive Ergonomics and the Irish Human-Computer Interaction Symposium. And with this introduction, I would like to turn it over to you, Raymond. I'm sorry if I misspelled anything or did not really, cover everything. And I will let you talk more about your work, the very interesting work that you have.
No problem. Really nice to meet you all. And my work, as Salah said, is right across the spectrum of applying data science and HCI research methods to healthcare. But today we're going to talk about HCI mostly. But what is HCI? HCI is a mixture of three disciplines: psychology, design, and computer science. Now, you need psychology to understand the human. You need to understand cognitive models, cognition, theories, mental models, and so on, but also behavioral psychology. You need to be able to do ethnography, observe human behavior when using digital technologies. And of course, you need design theory. That is, you need to understand and appreciate the psychology of color, graphic design, user interface design, and we'll talk about a whole group of laws of user experience design in just a moment. Of course, computer science is fundamental because we need to understand the limits and the opportunities in software development, and we need to appreciate the limitations and the opportunities in programming. Okay, so to really do HCI, you have to appreciate these three disciplines, and of course the domain that you're working in, which in this case is healthcare. And so I work in a computer science department, and in computer science generally, there's a large focus on artificial intelligence, which I also work in from an applied sense. There's logic and mathematics, knowledge engineering, robotics, there's software engineering, and algorithm optimization, and so on. But we need to focus on the user often in computer science, because it is users at the end of the day who will use software systems and digital systems. And this is a great quote from Jeff Bigham: "The two hardest problems in computer science are people, and convincing computer scientists that the hardest problem in computer science is people." Because in computer science, we can often focus on information theory and hard problems like optimizing an algorithm, a sorting algorithm, or improving deep learning neural networks in terms of its mechanism for training and so on. But people are also complex, as we all know. And when you observe people using technology, that's when you realize that we often have different mental models, and our behaviors can often be very different to the behavior that we expect. And we find that out as software designers. When we design something, we believe it's intuitive and easy to use, but it's only when we actually observe people using that we realize that actually interacting with a computer, a human interacting with a computer, is more complex than we often think. In terms of healthcare, an old but very well cited publication, to Err is Human, it became prevalent that this statistic, that there was a projected 98,000 medical errors in the US, and potentially some or many of these errors are related to poor medical device design. Now, there's other meta-analysis since then published in BMJ that would suggest that 1 in 20 patients may experience preventable harm or a preventable medical error. Now, if many of these medical errors are a result of poor medical device design, then we need to invest more time into human factors and usability testing and interface design. Now, we've had a little bit of history in some areas. We've done work in electro misplacement. So when you record an ECG, you obviously have to place 10 electrodes on the human torso, and 6 of those electrodes are placed on the chest, right? And these electrodes should be placed on very specific anatomical landmarks. For example, V1 should be placed on the sternal border in the 4th intercostal space. So they're very well specified. However, many electrodes can be misplaced. And what's the result of that? Well, if you misplace electrodes, you then interpret ECGs that are not reflecting a standard ECG, and that you might misdiagnose a patient, or you might not identify an abnormality that would be obvious if indeed you recorded the ECG correctly. There's many ways to fix this problem. One way is through hardware design, and there was a company that developed this cardio quick patch, which is a paper-based set of electrodes, 6 electrodes that you place on the chest, and it confines where you can actually put these electrodes. And it actually, in our research, it improved the electrode placement, right, of 5 electrodes, but also reduced the intra practitioner variability. That is, if a healthcare professional places electrodes onto a patient model, and then they place the electrodes onto the same patient a week later or 20 minutes later, then you're likely to be much more consistent in your electrode placement, which is important for things like serial comparison and ECG interpretation. Another way, of course, is to develop an algorithm that can detect electro misplacement. And indeed, we did develop a deep learning algorithm to detect when the electrodes are placed in the 2nd intercostal space. And this algorithm uses the ECG signal itself to determine if the electrodes V1 and V2 were misplaced. And this algorithm, it's binary. It either is misplaced in the second intercostal space or it's not. And we get a 93% accuracy in a balanced data set. And when I say a balanced data set, that means 50% of the ECGs were correctly recorded and the other 50% were incorrectly recorded. And we get a substantial performance, which is 93%. But interestingly, when you ask people who read ECGs to identify which ECGs are likely recorded from misplaced electrodes and which ECGs are correctly recorded, on a balanced data set, the accuracy was only about 60% in the humans. And at 50%, that would be random, the flip of a coin. So people are just a little bit above random chance when identifying that an ECG was incorrectly recorded. We have went beyond digital health, and we've done usability testing during COVID. We tested the usability of lateral flow COVID test kits in the home and also in cars. And we found that they were very user-friendly, independent of the user's age and education level. But of course, the agreement wasn't always perfect, but the agreement was very good. And when I say agreement, I mean actually interpreting the result on the lateral flow test. So how would a researcher interpret the result versus how the actual citizen or end user interpret the result? There is a substantial agreement, but of course it's not always perfect. And that's likely due to some, for example, the T line being very faint in COVID test kits. We've also done a lot of work on, understanding human machine collaboration, and we've looked at the human computer agreement in an algorithm that's used at the cath lab to interpret ECGs, and that algorithm can identify acute MI, but also the human reads the ECG and they can identify acute MI. And of course, we found that there was an agreement, but it was quite poor. That is the agreement between the computer and the human when identifying which ECGs are acute MI and which ECGs are not. And these are the ECGs that are referred to the cath lab. And I'll not talk a lot about this, but we are doing other studies right now on inter-rater variability. That is, different doctors or different healthcare professionals judging the same patient case. And we're finding that there's a lot more variability than you would think. Yes, we all know that there would be some variability. If you mark student coursework and you get 10 different people to mark that coursework, there might be some variability, and you expect some variability in different people reading an ECG or different people reading an X-ray. But often that variability is greater than you might anticipate, and which reminded me of a great quote from Daniel Kahneman in his new book called Noise. That is, wherever there is judgment, there is noise, and more of it than you think. And to keep in your mind, we need to consider AI and AI algorithms and try to evaluate whether AI algorithms can reduce this noise in clinical decision making. So let's go back to usability, right? And so if you use a defibrillator, or if you use another medical device, an infusion pump, you can say if you think it's usable or not usable. And often if you use something and you make a mistake, or somebody makes a mistake or makes an error when using that device, you might call it a user error, right? I often call it a usability issue, but you might just call it a user error. But often the case is that it's not a user error, it's a use error. And there is a difference. If you call it a user error, you're saying that the user was responsible for making that mistake when using that device. But a use error means that, yes, there was an error, but it might be due to the purely designed interface. So if the design is badly designed, and if the design entices people or induces the likelihood of an error, then the entire responsibility can't be on the user. And just this morning, when I read this book on usability testing of medical devices, and it, according to that book, 75% of user errors can be attributed to the poor user interface design. So we probably shouldn't use the term user error, and lots of other people are in agreement with this. We should use the term use error. Now, there's a whole bunch of different terminology that might seem synonymous in HCI. There's user interface design, there's usability, there's accessibility, and there's user experience design. User interface design is obviously having a graphic designer or an interaction designer deciding the best place to position buttons and menus and visualizations and so forth. Usability is about how easy something is to use. Accessibility is about how easy the interface is to use for people with different needs. Let's say for people with different visual impairments, speech impairments, and so on. How inclusive is the interface? And user experience design is beyond that. User experience design is more about how satisfied the user is when using that device or after using that device. It can also be about the look and feel of the medical device, which reminds me of a great quote that people may not remember exactly what you did or what you said, but they will always remember about how you made them feel. And often when we use digital products or medical devices, or a smartphone or any device, such as a website even, you might not always remember the functionality and the features, but often you'll remember how it made you feel when you used it. So what is good usability? For me, it's when the user doesn't need to think. Now, sometimes, of course, we do need to think, but we should be thinking about other things. We should be thinking about the goal when using a device. We shouldn't be thinking too hard about the process, because the process should be intuitive. And that's why Steve Krug entitled his book, Don't Make Me Think, which is all about usability. So to give an example, you might look at a door handle. You don't really have to think when you use a door handle like this. This is my door handle of my front door, by the way. It's a photo I took this morning. And because it is a handle is intuitive to pull, and our automatic reaction to a handle is to pull it. Now, you've all come across doors where it has a handle, but indeed the mechanism is to push. And often we go up to those doors and we pull and pull and pull until we realize actually we should push. That is an example of a very poor user interface design. And so this idea of the intuitive reaction to the shape of objects and so on is called affordance. That is, we know what a button is when we see one, and our automatic reaction to a button is to click on it. But often poor interfaces have buttons that don't look like buttons, and that would be regarded as poor affordance. And this is related to System 1 and System 2 thinking, which I'm sure you've all come across. It's the dual process theory of cognition, often discussed and tested by Daniel Kahneman, who's attributed to this theory in his seminal book, Thinking Fast and Slow. That is, that this theory tells us that we have two ways of thinking. System 1 thinking is our intuition. It's effortless. It's how we look around a room and know that a chair is a chair. We don't have to calculate the dimensions of the object. We don't have to think about the relationships of different aspects and features of the object. We're not mindful and conscious of doing any of that processing. We just know it's a chair. And that's System 1 thinking. It's effortless. We don't waste energy. We don't feel like it's making us tired. It's very easy for us to do. But System 2 is where we do things like arithmetic, and we have to reason and be very conscious of our reasoning, and it can make us feel tired. And it's slow thinking because reasoning and calculating numbers and so on. Even though it's a few bits of data, it takes a while to do, and it's difficult. But if you keep the user in the system 1 zone, then your product is user-friendly and usable. But once the user has to flip to system 2, then it becomes tiresome and taxing to use that system. So in HCI, there's many different design methods. When you design a product, you get the requirements. You might do focus group surveys, and you might even do design thinking. Then you might design the user interface with professionals. Then you might design the user experience, which is more about, are users satisfied when they go through this journey and so on? Does the product fit nicely into a service? And then you might do usability testing and UX testing. But when you design a user interface, you often design with certain laws and guidelines and principles, right? And I've named a few here, like Miller's Law. Usually when you design an interface, you're conscious, or you should be conscious, that humans can only hold a certain number of items in their working memory. According to Miller, we can only hold around 7 items in our working memory at any one time. So we shouldn't be presenting too many options and so on. Hick's law is related to this in some way. Hick's law is that the amount of time it takes you to make a decision is a function of the number of options. So if you provide too many differential diagnoses, for example, or if you provide too many different options, it can really take a very long time to make a decision, which seems obvious. And there's a lot of research on this, which would certainly interest you. It's why I imagine a lot of supermarkets might decide not to have too many flavors of jam or crisps in a certain aisle, because if you're faced with too many options, you might not make any decision at all, and you might have this kind of decision paralysis. Serial position effects. You might design an interface knowing that we're more likely to remember the first and last items on a list. So if you're presenting a list, and you're reading that list, you're more likely to remember the first and last items, which is known as the primacy and recency effect. Jacob's law, for example, is the fact that users become familiar with certain features. For example, if you're browsing many websites, you get familiar with the idea of blue text becoming hyperlinks. And once you standardize that concept in your mind, you start to expect that all blue links in all other websites will also be hyperlinks. I'll not go into the other laws, but there is a great book here, Laws of UX, that I've cited that you might want to look at. But the point here is that we often would design an interface with these laws in mind. You'd also be mindful of something that's known as Gestalt psychology. Gestalt means shape, and it's the appreciation that humans use a lot of our brain for visual processing, and we interpret shapes automatically in our system 1 cognitive system, right? So, for example, here we perceive that there is, let's say, eight rectangles, but once you change the position of those rectangles, we automatically now perceive that there's 4 groups of 2. And we do that automatically. We now perceive that there's 4 groups just by changing the proximity of certain elements. By changing the color of one element, we now automatically perceive that one element is more important than the other. And this is known as visual hierarchy. So the pink rectangle now becomes more important and dominant in our mind. And you can go much further with visual hierarchy using not only color, but also shape and size. And by changing the visual hierarchy, changes the order at which our eyes fixate on different bits of information on a screen. So I came across this quote, which I thought was quite good. A user interface is like a joke. If you have to explain it, it's not that good. Okay, so what are the actual factors of usability in UX? Well, Jacob Nielsen, who is a pioneer in the field, he would say usability is about the learnability of the product. It's about the efficiency, how, can you complete tasks within an amount of time that's reasonable. Memorability, can you remember how to do things when you go back to the interface? It's about errors. Do users make critical errors when using the device? And it's about satisfaction. How satisfied are users when they use it? Are they frustrated, or are they satisfied? Then there's a bunch of other UX metrics that you might add to this, like, is it delightful to use? Is it desirable? And so on. But how do you measure? So we've talked about designing user interfaces. How do you measure it? There's many ways, and we have done usability auditing, for example, which is a very cheap way to evaluate a user interface. Usability auditing is a bit like taking those laws that I talked about and using those as a set of principles and guidelines, or a checklist, to audit an interface, to actually go through an interface, do a cognitive walkthrough through the tasks as an expert, and identify which aspects of the interface don't comply with your set of guidelines. As I said, the set of guidelines can be based on the literature and be based on those UX laws and principles that I discussed. Or you can do lab-based usability testing, where you get users into a lab and you ask them to complete tasks whilst they think aloud. So they say what they're trying to do, and you record that. And that way you can identify the usability issues and barriers that they came across. And you can also calculate how long it takes them to complete a task. And often I would compare how long it takes users to complete a task against how long it takes an expert, somebody who actually knows the interface well. And if somebody's if a novice is taking 3 times longer than the expert, then the interface may not be as intuitive as you think. Then there's the third way of doing it, of evaluating UX, which is real world user log analysis. And this is something we have done a lot of recently. For example, if you've designed a healthcare app, or indeed it can be a medical device, if that device or app logs every user interaction, that is, if somebody records their blood pressure on an app, you might log the date and time at which that feature was used, and so on. And that can go from every interaction. So even just logging into an app, or turning it on, or using any particular feature, you can just log the date and time, the event type, which in this case might be blood pressure logged, and so on. And by creating a large database like that, you can mine that using machine learning and data science techniques as well, to look at things like user retention. How long do people use your app? As we also call that user tenure. And you can also look at the types of users that are using your app. And we use things like clustering and so on, which I'll mention. Now, as well as doing the user log analysis in the real world, because it is real world data, whereas in the lab, you're really just seeing how people use your device in a control setting. But by doing user log analysis, you're getting data from the real world, which is another benefit. However, we have done a series of traditional lab-based usability tests, and we have worked with many others in doing this, such as Richard Fiddler, who did some nice human factors analysis of bedside monitors. And yeah, you might know that there's often a problem of alarm fatigue, which is people often ignore alarms that are going off on a bedside monitor because the alarms have a lot of false positives. So we can then become prone to ignore those alarms. But in this study, it was interesting that we found that there was a lack of proficiency around setting new personalized alarm thresholds on the device itself. And I remember talking about this study and somebody mentioning that but can users not just use the user manual? And I think we're at the age where we don't use a user manual for our smartphones, which are very complicated systems. And I think we're at the age where we need to replace user manuals with intuitive user experiences. We've done other usability testing, traditional usability testing, where we've looked at different types of digital health forms. So when people are referred to the cath lab, and in this instance, there would be a paper form that somebody would complete, and they might complete the ECG findings and whether they had chest pain and so on. And they're paper forms, right? And often those paper forms then would be transferred to a spreadsheet, and then the spreadsheet is used for auditing and analysis, internal analysis. But of course, we are in the digital age, so a lot of these paper forms should be digitized for many reasons, such as data quality and so on. And so we looked at different types of digital forms. So you can have a traditional single page digital form where all the fields are in one page, or you can have a multi-page form where you can segment the questions over a number of pages. And that kind of breaks down the task. And so there's reason to believe that would be a better approach. Or indeed, you can have a conversational form, which is like a chatbot, where you only get presented with one question at a time. The first question might be, does the patient have chest pain? What time of day did they experience the chest pain? And so on. And now the problem with that is you can't easily go back to correct previous answers. But we tested the usability of these different types of digital forms, and we found that people are obviously more efficient with the paper sheet, but that's probably due, or could be due to the fact that they're well trained and familiar with that method. But after that, we find that people were much more efficient with the single page form than the multi-page form, or indeed the chatbot based form. And so we've done usability testing of different types of digital forms. So to go back to what we were discussing a minute ago, you can do traditional usability testing in a lab where you get users to think aloud. Before users do a task in a lab, I often get them to rate how difficult they expect the task to be, because in that way you're recording the anticipated user perception of the difficulty. So you know, when we go to use a system, let's say we go to use a self-check-in at an airport, we have an idea or an expectation of how difficult that task would be. So after users do the task, I then ask them again, how difficult was the task actually? And we would compare the difference between the perceived task difficulty and the actual task difficulty, which is an interesting metric. After users do all the tasks, we often get them to complete a system usability scale, which is a standardized scale to measure usability, which gives you a usability score that you can benchmark on a distribution. So you can say things like that, you know, your device is more user-friendly than 95% of every other device that was used to test using this SUS scale. But of course, we're moving on to more real-world usage analysis, which is where we actually log every interaction with the device in the real world and we analyze it. This is the kind of database that you might record. You can see that you have the date and time and event type. And what you can do to augment that database is to also do what's called ecological momentary assessment. So if you wanted to know how satisfying or how user-friendly the device was in the actual moment of it being used, and of course you have to be careful here that it's not in a critical scenario, but if you wanted to know how usable something is in the real world, in the actual moment of use, you can have pop-up questions that would ask the user about their current experience. This is known as ecological momentary assessment because you're recording data in the natural ecology as opposed to in a usability lab. Which reminded me of this fantastic illustration of how you might design a device and an interface and expect people to use it, and how people actually use it in the real world. So people might use it in the real world and take a shortcut and take a very different path when compared to what you expected when you designed it. So we've done user log analysis across many apps, one being the Inspired app, which is an app for people living with dementia, and it's to facilitate reminiscence. So people living with dementia can reminisce about the past, let's say about old photos where they grew up, their wedding, their childhood, but also listen to music and also watch videos. Now, in this study, we were primarily interested in, does reminiscing for people living with dementia, does reminiscing improve how close they feel to their spouse or partner? We call that mutuality. Mutuality is how close you feel to your partner. And indeed, reminiscing using this app did actually increase mutuality. And when you think about it, it makes sense, because if you're reminiscing about the past using this app with old photographs and so on, it's likely to initiate more conversations and higher fidelity conversations, and allow somebody to share more experiences with their spouse and have a conversation that allows them to feel closer or more intimate, or indeed increase their mutuality. But whilst people were using this reminiscing app, we logged all the interactions, and we were able to see that people reminisce in the morning just after 10 o'clock, in the afternoon around 3 o'clock, and in the evening around 8 o'clock. So there seems to be 3 peaks during the day when people prefer to reminisce. And you can also see that reminiscing does go down at the weekends, which is quite interesting as well. But what you get when you do user log analysis, you can have these user dot charts, which allows you to look at the x-axis, which is time, and the y-axis can be the different features of a medical device or an app. And you can see when a user used a particular feature on that app over time. And that really allows you to really understand the full real world user experience of a device or an app. Here, instead of saying user 1, it does say dyad 1. The reason why it says dyad 1 is because in this study, there were 2 users for each app. There was the spouse and the person living with dementia. So we have called it dyad 1, dyad 2, and so on, as opposed to user 1 and 2. But what we also typically do when we record user log data, we do things like clustering, which is a machine learning method to discover the types of users of that app, right? And basically what you do, you derive features or characteristics for the users. For example, you might think, okay, for each user, I want to know how long they use the app for. You might want to know the standard deviation of days between the usage of the app or engagement of the app. And you might come up with different characteristics like that. And then you might do clustering, and that will tell you the types of users or the phenotypes of users that are engaging with the app. And in this example, you can see that there were 4 groups or 4 clusters. In one cluster, there was only actually 1 user, which was a very high adopter who was a significant user of the app. They used it very frequently and so on. And then you have the different groups here, which I'll not get into. In the Reminiscence app, we did use ecological momentary assessment, where we had pop-up questions that would pop up during the reminiscing session, and might ask them a question about how close they feel to their spouse, for example, and then they would answer that. Interestingly, what we found is that people would dismiss that pop-up question in the morning, but they're much more likely to answer that pop-up question in the evening at 9 p.m. That is, the dismissal rate of that pop-up question is really low in the evening. In other words, people will answer, or will be more likely to answer, your ecological momentary assessment questions in the evening. Now, we call it EMA for short. EMA gives you very rich data. It gives you explicit data as opposed to implicit data, the implicit data being the log data. So EMA can be used to enrich your data collection. Another body of work that we're doing at Ulster is we are working with ORCA, which is a UK organization that validate and approve digital health apps. And what they do, if you submit a digital health app, they will assess that app for data privacy, user experience, but also professional or clinical assurance. That is the content reliable and dependable? And at the end of that assessment, you get a score out of 100. And if your score is above a threshold, then your app is approved. If your app is approved, then it goes on to many approved app platforms at the NHS or indeed other healthcare services. And I know in Northern Ireland, we have our own app platform where we have approved health apps on that platform. The result is that healthcare professionals can then recommend and prescribe those health apps with confidence, knowing that they have been assessed and quality assured. And this is really important because 80% of health apps don't actually meet the ORCA quality threshold, which is alarming, but also justifies the case for having an approval process like ORCA. Now, we have done some analysis of this kind of data because we do have the data that was used to quality assure these many apps, over 2,000 apps. And we can look at the quality of apps across different disciplines. And you can see, for some reason, urology, apps related to urology, there are only 20, seem to be of very high quality according to the ORCA score. But as you go down this list, you can see that apps related to allergy and ophthalmology seem to have poor quality scores. And so it allows us to identify perhaps clinical areas or healthcare domains that need more attention in terms of the quality of healthcare apps. One other problem we've come across in healthcare apps is user retention. That is, I think most healthcare apps are downloaded and deleted, right? And people don't have a sufficient user retention when using a health app. How do we improve user retention? That is an open question that we need to think about. And we don't really know why, and it'll be different for different users, but we don't really know why user retention is so poor when it comes to health apps. These are some general recommendations based on my own experience when doing usability testing. One is you can increase the fidelity. So we do usability testing with defibrillators. What is the real world environment that people use defibrillators with? Is it a noisy environment? Is there distractions? Think about what actually happens in an emergency scenario. Is there cognitive tunneling? Is there restricted mental workload? And so on. Another bit of advice is that you should only ask users to start a task when they have fully understood the task. Because in the real world, if you have a goal when using a device, you know exactly what your goal is. Whereas in a usability lab, you're having to give that goal to a user, and a user might start a task before they have even understood the task. And you can see the other kind of recommendations that I'm giving here. As I said, we've done usability testing with defibrillators. We've used eye tracking to try and understand where on the defibrillator people are looking. We've done eye tracking with different defibrillators on a screen, and we've found that there is great variability in terms of what people look at first, second, and third. We call that a scan path. And of course, your scan path should be optimized. You should be looking at the most important things first. The most important thing is, of course, the on button. But at what stage do you actually fixate on the on button when looking at a defibrillator? Just to give you a simple example. We've done eye tracking with in clinical decision making to try and understand how people read X-rays, and we did find that there is a link between eye gaze behavior and your competence, which does make some sense, and I've left a reference here. We have done eye gaze analysis when people read bedside monitors, the vital signs. And again, we did find a link between visual attention and performance. And we used regression with that. We've also done eye gaze analysis in a simulated cath lab environment using this Mentis device. And I've left the citation if you want to know the details. But we find that there is a difference in dwell time, eye gaze dwell time on the screens between trainees and trainers, trainers being the experts and trainees being the novices. And that probably showcases that trainers or experts have greater spatial coordination during a cath lab procedure. They're able to look at the screens whilst using their psychomotor skills. And of course, we also find that experts have greater transition frequency across the different screens. You might have the angiography screen and you might have the vital signs screen, and the experts cross-reference more often or more frequently across those screens when compared to the novices. So we're really moving into the AI phase of the presentation, and we know that AI algorithms are being developed for medicine. The FDA are approving AI algorithms and so on. And so we need to have a new set of principles when developing user interfaces that have AI built into them. Because at the end of the day, many algorithms do have a user interface that sits on top of that algorithm to present information to the end user. And so we have the Nielsen principles that we mentioned earlier, but we also need human-centered AI principles. Things like, is the algorithm ethical? Does it have bias, algorithmic bias? Is the algorithm explainable and trustworthy, and so on? And we know that there are many types of algorithms in AI, and one of the more popular types is neural networks. Indeed, deep learning or deep neural networks, where you have many layers. And when you have many layers and many nodes in this neural network, it becomes a black box. That is, that whilst the neural network might have a lot of predictive power, it might be very good at recognizing certain diseases and so on, pathologies, but you can't actually explain its reasoning or explain why it made a certain decision. But of course, you might say that humans make a lot of decisions that they themselves don't even know why they made that decision. And yes, we call that tacit knowledge, but yet we hold computers to greater accountability in terms of the explainability of its algorithms and decisions. And of course, by making algorithms explainable, we learn. We maybe even discover new criteria, new diagnostic criteria. And so there is a benefit to explainable algorithms in terms of education as well. So there is a great phrase, a great quote from Fei-Fei Li that I often use, that is that AI is a machine that can make a perfect chess move when the room is on fire. And that's just to recognize that the human is responsible for the ultimate decision in medicine. The computer doesn't understand context and nuance, and doesn't have the other information that you have as a healthcare professional. And however, I'm also reminded of another quote, that is that AI will not replace clinicians, but clinicians who use AI will replace clinicians who don't use AI. And they're two great quotes, and the latter might be a bit harsh, but it isn't my quote. Okay, so just keep me up to date with time. I realize that I'm talking a lot, and just interrupt if you do have a question. But the next this part of the presentation is still about AI and some of our work on automation bias, and that is the recognition that.
So Raymond, it's almost 11 o'clock, and I know some of people here might have other meetings. How much more time do you need?
Well, I can finish in 5 minutes if that's useful. or I can stop now if you want to.
Yeah, so I'm fine with staying 5 minutes. Is this okay, Annette?
I think we can have anyone who's willing to stay on, we want to hear, but maybe this is saying we should have a second installment of your presentation, which we could arrange sometime this summer.
Or maybe let's see if you can, cover whatever you want in 5 minutes, then we can make that decision,
Okay.
whether we need to come again or not. Yeah.
Sure.
So yeah, I won't interrupt you. So keep going. 5 minutes is great for now.
Okay, and I'll just go through these slides and give you a flavor for the other work that we're doing. This work is about automation bias. It's the recognition that if an algorithm just presents its recommendation to humans, the human might become over trusting of that algorithm and might just accept every recommendation. And that's known as automation bias, or I would like to call it AI spoon feeding. And we've done research in that area, particularly in the ECG interpretation, where the computer does recommend an ECG interpretation at the top of the page. And what we find is that when the algorithm is reliable, the human interpretation accuracy is quite high, as you would expect. It's like 84%. But once the algorithm is providing recommendations that are misleading or incorrect, the accuracy can drop to as low as 27%. So this was some evidence that some people are just over trusting the algorithm, and we need to provide more information than just the algorithmic recommendation. We need to provide information about the probability or the level of certainty of the algorithm. So if the algorithm is not very confident in its suggestion, then we need to have data about that. If the algorithm is using features or variables that that are likely incorrect or incorrectly measured due to noise in the signal, for example, then we need to provide that information to the end user. We also need to tell the end user how accurate the algorithm typically is for these different interpretations. What we did in a follow-up study, we found that when you present an ECG algorithmic recommendation alongside a level of certainty, people can perform better. For example, when the algorithm provides a recommendation, but it tells the user that it's very uncertain, then people do have a higher diagnostic accuracy because they then take on that responsibility to ensure that they interpret the ECG correctly, perhaps. And so we need to present all of this other metadata and information to the end user so that they can make a better decision when using computerized algorithms. Okay. What we also believe is that when we're making decisions in healthcare, we need to consider the optimal order of the information. That is, if you read an algorithm's recommendation first, you're going to be anchored to that suggestion, and you may not interpret all of the subsequent data that you need to interpret. But if you leave the algorithmic recommendations to the end of the information flow, then you might be less biased in your actual clinical decision making. This is a childish example of the order of information, and it's an example of that the preceding information can prime how you interpret the following information. For example, if you read this from left to right, you read A, B, and 14. But if you read it from right to left, you might read it as 14, 13A. It's a very simple example of how preceding information can influence the proceeding information. And we have done that with the ECG, where we've deconstructed the task of ECG interpretation over many different subtasks, which is known as linear sequential unmasking, which is that you don't reveal all the information in the first screen. You segment it over many screens and ensure that there's no bias in the decision process. And we're doing research around that, which I can talk about at another time. One last project that I do want to highlight is that we have developed a chatbot to support mental well-being. The chatbot delivers positive psychology content to promote a positive mindset. But the problem with chatbots is that who wants to talk to a computer? But actually, people are using things like Alexa and smart speakers today. We do speaking and is a natural way to communicate between humans. So why couldn't speaking be a natural way to communicate with computers? So there's mixed reactions to the idea of chatbots, but I'm sure you have your own opinion, and I'll not get into the different nuances there. One of the ethical issues in this area was that a chatbot can only deliver pseudo empathy. It's not an actual human. You are humanizing the technology, but at the end of the day, it doesn't have true emotions. And that's a problem when using chatbots in mental health care. Okay, I'll not get into these other studies. They're mostly about chatbots and speech analysis. Minear is a project where we're actually doing that. We're doing some speech analytics to see if there are any biomarkers in speech that could indicate depression or mental ill health. Okay, so I'll end it there, and I'm happy to take any questions from anybody. Apologies for going over time.
Raymond, this has been fabulous introduction to a wide range of work that you're involved in. I have several questions that I don't think we have time for today, and I think other people will have follow-up questions. Maybe Salah and I can talk about how to facilitate getting more discussion or Q&A type activities.
Yeah, maybe we can have a workshop or maybe just a panel as opposed to a presentation in the summer or another time.
Yeah. Maybe we could start to compile kind of the list of questions that people have, that you've prompted us to think about in relation to the work each of us is doing. Because as I said, I personally can think of, I've jotted down like 6 questions that I'd love to hear more about. So
yeah, even if you wanted to email me those questions or put it in the chat, and I can respond with an answer, or even just think about them, and we can use those as an agenda for an action. So if people have questions, we can actually just use the questions as the discussion points.
So maybe Salah, we can talk about that more.
Yeah, I had to step away for a few minutes, but I think, yeah, I completely agree with you, Annette. And this has been like a wonderful presentation.
Absolutely.
I echo that statement. So thank you so much for, giving this presentation, Raymond. It's always a pleasure to hear your work.
Good.
Yeah.
Very happy to do it. And it's a pity we couldn't be in person. I always find it strange doing it to a screen, but because I don't get to see your faces when I'm presenting. I just get to see PowerPoint.
Well, it was a very rich presentation that's prompted a lot of thought, and I'm sure we'll be in communication.
Good.
Thank you. Okay. So
thanks, Salah.
thank you so much, Annette, Raymond. Take
Bye.
care.
Okay, bye.